Welcome to the first episode of Carilion Clinic's Antimicrobial Stewardship podcast. We plan to use this series to discuss topical infectious diseases issues. This series is being made by medical professionals for medical professionals. I'm this episode's host, Nathan Everson, a board-certified infectious diseases pharmacist and lead of ambulatory antimicrobial stewardship efforts at Carilion Clinic. Today, I'm here with Dr. Elizabeth Nowak and our infectious disease pharmacist, Dr. Nicholas Stornelli. And I'm going to let them introduce themselves. Dr. Nowak?
Hi, I'm Ellie Nowak. I'm an infectious disease physician at Carilion Clinic, and I practice both inpatient and outpatient.
And Dr. Stornelli?
Good morning. It's really exciting to be on this podcast, the inaugural podcast. My name is Nick Stornelli. I am one of the inpatient infectious diseases pharmacists based out of Roanoke Memorial Hospital. I'm excited to be on the show today and chat with you all a little bit about ASB.
Awesome. As Nick mentioned, our topic today is one of those classic issues in infectious diseases, but often more complex than people realize. What do we do with asymptomatic pyuria or bacteriuria, which we'll refer to as ASB during this conversation? I have some kind of pre-planned questions for our collaborators today, and I'm going to give both of them opportunities to discuss their practice perspectives and evidence when it comes to managing ASB. All right, if you two are ready, we'll launch right into the discussion. So let's kind of start with the what and the whys of ASB. So I think that there's sometimes confusion about what is actually considered ASB. Also, why do patients have ASB and why does it come up? Is it a bad thing? I think a lot of us have always heard the dogma of like urine should always be sterile, so ASB seems like it should be bad when it's there. So I will kind of start off with Dr. Nowak, and what are some of your thoughts here?
Yeah, so I always grew up with the misconception that if you get a jellyfish sting, someone should pee on it because that will sterilize it. This is absolutely incorrect. Our urine often has bacteria in it, and the rates of asymptomatic bacteria actually go up as we age. So children have much lower likelihood of having bacteria in the urine, but that goes up over 80 years old. There's over 50% asymptomatic bacteria that's noted. And the IDSA defines asymptomatic bacteria as one or more species of bacteria in the urine, as defined by more than 100,000 colony-forming units, but that's kind of a mouthful. I think that the main takeaway from that is that there's bacteria that's present and it doesn't matter if you have pyuria or white blood cells, leukoesterase in the urine, and it doesn't really matter if you have the nitrates on your urinalysis. So we're really trying to focus in on the culture results there. And then these cultures should be taken under sterile conditions. I think that's another really important point. They need to be midstream urine, not contaminated with anything else. And the patient should be asymptomatic.
Great, thanks, Dr. Nowak. Dr. Stornelli, do you have any additional comments about ASB?
Yeah, Dr. Nowak, thank you for sharing that anecdote. Kind of a similar, I think, initial philosophy from like a cultural perspective, but to your point too, like, urine is not sterile. There's some studies and kind of reports of even in healthy volunteers, when they do midstream collection, multiple aerobic and even anaerobic organisms isolated from those patients under, non-symptomatic conditions. And so to your point too, like, our flora changes over time as we age, as we go through and experience maybe certain complications from a urinary tract anatomy perspective. That's going to change over time. And so all of those points kind of hit home to, is the urine actually sterile? And, the short answer is really no. It also depends on how well it's collected. As you mentioned, if it's not midstream, like you got to kind of look at exactly what you're collecting from. If it's from a Foley or a catheter, you're kind of looking at not necessarily urinary tract colonization, and you're throwing a little bit of prosthetic or plastic material into the mix there. And so, yeah, in short, I agree. Urine is not sterile, or it's rarely sterile. and we need to be collecting it in the right folks.
Yeah, and to that point too, I think as we age, there are some factors that start to impact bacteria sort of taking over our urinary tracts. And one of those is, especially in women, the decrease in estrogen levels can lead to certain bacterial populations increasing. And therefore, there are some changes in pH. And so that can increase the likelihood of gut colonization into the urinary tract. And women are especially susceptible to this as they age, not only because of those fluctuations in estrogen, but also because of, in theory, a shorter urinary tract. So it is really common and really normal to have changes in those populations. But I think that what a lot of the literature focuses on is that the shifts in these bacterial populations are actually the bacteria that we find are often less virulent than in folks that do have recurrent urinary tract infections. So the folks that have asymptomatic bacteria, those populations of bacteria are often just hanging out. They're not actually causing harm. And so it's not exactly the same thing as in patients who keep getting these recurrent UTIs over and over again.
So would you almost go on to say that like the difference between ASB and actual symptomatic UTI is just, the host defense, and if that's compromised, then we're more likely to see infection, and we should really be thinking about those factors in kind of scenarios like this?
That's a great question. I think that there probably is some dysbiosis that's going on that's underlying all of this, in addition to the host immune factors. But if we see shifts in the populations of bacteria to strains that are more pathogenic, then folks are going to have more symptomatic urinary tract infections. But I do think that you're correct in that there is probably some immune function that goes into it as well.
Thanks, guys. That's fantastic. I think we kind of covered some pretty important concepts. I think from what I understand is that, treating ASB has changed over a long period of time, and that there was a period of time where the thought was if you see bacteria in the urine, it shouldn't be there. We need to treat it. And that has shifted considerably to treating only in very specific circumstances where there's risk. And so I guess that's a really good transition for us to talk about when should we actually be recommending the treatment of ASB and the culture, or when a UA is indicated, and when we should actually treat the ASB if we find it. I think that as a stewardship pharmacist, I'm constantly looking at charts and reviewing things. And one of the most common things I think I see is UA indicative of UTI, or UA positive, start a medication, which is not taking into account symptoms or the assessment of the UTI, whether it's lower or upper or anything like that. So, I'll start with Dr. Stornelli on this one, but, what are your thoughts about situations where we do have an indication to treat ASB?
Yeah, I love that you kind of brought in that point of the line in the chart. The number one problem is that the UA, is indicative of urinary tract infection. I feel like that is kind of the biggest kind of misnomer. I mean, it's one component of that, like assisting in kind of discovery of if your patient does have an actual infection, but it needs to be paired with those clinical symptoms. As Dr. Nowak kind of talked about with, the change over time in elderly patients, kind of this idea of host defenses and when might be appropriate for ASB, there's really only a few primary indications for ASB treatment. The major indications to treat for asymptomatic bacteriuria, the ones that are guideline-based recommended indications are patients of pregnant status, looking at patients that also have planned procedures, urologic procedures, so prior to transurethral resection of the prostate, or any sort of urologic procedure with mucosal bleeding or trauma are generally going to be your preferred indications to treat for ASB. There are some indications that are maybe a little less guidance and a little bit more controversial, such as those that are bacteriuria that are persisting beyond 48 hours of indwelling catheter removal. Those are generally going to be a pro-con discussion about whether treatment is indicated in those situations, but are situations that may have consideration for treatment implied. And then looking at kind of unique patient populations where We often don't have a lot of treatment guidance or guidelines for how to navigate. Would be patients, neutropenic patients. These ones don't necessarily have a lot of guidance to dictate whether or not treatment is indicated. And then thinking about other populations as well, renal transplant, which we definitely don't see a lot. There might be some implications for treatment of ASB within 1 month of renal transplant. Obviously, these are very different patient population based on surgical procedures, and then there's a lot at stake with having a new renal transplant in these patients.
Talking about some of these like controversial ones, like I know that there's been some data for, or that transplants used to be a treat ASB in all situations, and transplant centers are moving more towards not treating every ASB, knowing that reducing normal flora can be problematic, particularly for transplant patients. But knowing kind of those the catheter and the neutropenia and transplant, Dr. Nowak, in your practice, seeing these patients in the hospital part of infectious consult, what are some of the thoughts you have in terms of when you might treat some of these ASBs versus not in these patient populations?
Yeah, it's a great question. I think it's really case by case. So we tend to treat more aggressively or more often if there are signs or symptoms of a urinary tract infection. So folks that have evidence of fever, white count, and have the nuance of perhaps having some immunocompromise in their background, we would err more on the side of treatment. Honestly, like neutropenic patients, we usually don't treat even then, asymptomatic bacteria. And I think the IDSA kind of hedges on it. They don't give great guidelines just because they say that there's not like a good amount of evidence. But I think even in a neutropenic patient, if they were afebrile and otherwise didn't have symptoms, I'm not sure we would launch into treating that.
I mean, it's definitely a really difficult question to answer regarding patients that typically weren't included in the 2019 ASB guidelines. And so they don't really address a lot of populations, including neutropenic patients or even solid organ transplants. And so I definitely think that, there's a high chance in a lot of these populations that you will see bacteria in the urine, but there's not necessarily strong recommendations for if your patient becomes neutropenic or is anticipated to become neutropenic, that's a strong indication alone to prophylax for it. And I think that that's probably one of the biggest points in kind of these protected populations of impaired immunity. Just because the immune system has some dysregulation doesn't necessarily mean we should be using antibiotics preventatively.
There is a lot of evidence behind treating pregnant women with ASB, and that is because they have more of a likelihood of developing pyelonephritis, and that's actually been demonstrated in studies, granted from the 60s to the 80s, so they're older studies, but pregnant women, I think, are a particular important group to screen and test. And there's also been links to infants born with lower birth weights and preterm birth risk. So there is a lot there to suggest that that is the correct way forward. And then the other thing I wanted to just mention was that for folks that are going through urological procedures that are anticipated to have mucosal injury, it makes sense to screen and to treat those people. But that process looks a little bit different, I think, than what our standard workup looks like, because those are people typically that are planned to have a procedure. So we know ahead of time that they have this upcoming procedure. We screen the urine, and then we know what the isolate looks like so we can target it. And usually that treatment course is actually 1 or 2 doses rather than a full treatment course for a urinary tract infection. So it looks a little different than what we do in a normal population.
So we're talking a lot about who we should target and when we should treat. And, I feel like an easier answer would be, oh, if you have ASB, just treat it just in case. And that is definitely a lot of folks' approach is, well, I'm not sure, it could develop into something, it's making me nervous. I don't want the patient to like leave my presence and then something happen and they develop a UTI or pyelo and have to come back. So can we like, what's the rationale behind why we're trying to avoid treatment? What are some of the major consequences of going ahead and treating that ASB? And I'll start off with you, Dr. Nowak.
Yeah, I think there's the main concern there is the risk of unnecessary side effects from antibiotics and then the development of multi-drug resistant organisms over time to the point where you may not have oral options available anymore for treatment when you actually do need it. And so I think a lot of times as providers, we want to make sure that we're kind of covering our bases and that we're providing adequate treatment for people. And it feels bad to not treat something that we have found. However, if you reframe it as you are actually protecting this patient in the next situation where they have a true urinary tract infection, then that can kind of hopefully help us put our hands in our pockets a little bit when that's needed.
Yeah, for sure. Dr. Stornelli, do you have anything you want to jump in on that one?
Yeah, it's a really great question to be asked, like the why. It's like why is it bad to treat this? It's a positive result. It's kind of flagging me in my electronic medical record. It looks like a critical value, depending on your scenario. I completely agree with Dr. Nowak's point. We don't want to run the risk of exposure to antimicrobials when we don't have to, worry about resistance and obviously adverse effects. Particularly, some agents are very different than others in terms of their ability to increase C. difficile risk, as well as off-target adverse effects, such as those provided by our quinolone agents, which often or may get used. But there is also kind of this impact on your patient's outcome too. We in infectious diseases don't often get a lot of randomized or prospective data, but we actually do have some literature out of clinical infectious diseases from 2012 by Kai and colleagues, which is a very interesting article. And they actually look to kind of study the impact of treating asymptomatic bacteriuria in this controlled fashion. This was a study that looked at women ages 18 to 40 years old that were asymptomatic at enrollment. And they did have urine cultures that met that criteria that we talked about before, with the colony forming units of greater than 100,000 at enrollment. And so they looked at the patients that were treated versus placebo. So patients receiving antibiotics versus placebo at 6 months and at 12 months. And they really found some compelling findings. And so they found that 30% of patients versus 8% of patients at 6 months for those who received antibiotics versus placebo developed a symptomatic UTI. And that was a clinically and statistically significant finding of this study. And then also within 12 months of the study period, they did find that similar finding with 73% of patients who received antibiotics for asymptomatic bacteriuria versus 15% that did not went on to develop a symptomatic urinary tract infection. So these percentages are really great, but when we kind of look at the numbers needed to harm or the exact amount of patients to be treated that would see a negative outcome for the 12-month period, the number needed to harm is 2. So when you really think about that, it's not like it takes a lot of patients to really see a negative impact. For every 2 patients, you have to be thinking about the impact of a downstream effect of a symptomatic urinary tract infection, not just cystitis, but thinking about all of the ascending processes that could be a negative impact, pyelonephritis, potentially gram-negative bacteremia. And so this is one piece of data, piece of literature and ID that I think is really helpful. And I usually try to kind of bring this into the conversation about, reaching out if it's a patient in the hospital or one of our rehab facilities where there's treatment ongoing. It might be over a really broad spectrum of activity antibiotics on board. And this is a really great piece of literature that I will attach in our kind of show notes or references for this podcast to kind of incorporate. And so withholding antibiotics for ASB in the right populations is actually protective for preventing symptomatic urinary tract infections down the road.
I don't feel like this is like incredibly shocking information either in our current where we are in evidence. I think when it came out, it was relatively shocking, but the more we learn about the human microbiome is that it's like an essential part of your immune system. So anytime we're altering it, whether we're using chemotherapy or antibiotics or anything else, we run the risk of creating harm for our patients through kind of a de facto immunosuppression. So I think that study definitely makes sense, though I don't think we classically think of the GU as having its own flora, but like everything in our body has its own flora. So I think thanks for your guys' observations here. And I think that the ASB message has been sent. I don't know that everyone necessarily always has heard it, depending on what their practice is like. And we know ASB is overtreated. There's dozens and dozens of papers on it. It's a big focus of like the IDSA. It's part of a lot of stewardship programs. But we also know that clinicians want to do the best thing for their patient. Like they don't want to put a patient at harm. They don't, they want to do the thing that's going to have the best outcomes for patients. So, given that there's a kind of this dichotomy of like treating ASB maybe mostly negative in terms of patient outcomes, but we still see a lot of it, and we don't want negative outcomes. What do we think are some problems of why that's happening? Where's that disconnect? Happening amongst our medical professionals. And I'll start off with you, Dr. Nowak, if you have any thoughts on that.
One area where a lot of confusion or concern comes up is just with our elderly population or in folks that it might be hard to get a good history in or even a good physical exam in. So I think that tends to be sort of a gray area that people try to err on the side of caution, especially when you're dealing with someone who's a little bit older or perhaps immunocompromised, and you don't feel like you can have a really good analysis of whether or not they have symptoms of a urinary tract infection. I think that area tends to be one where maybe people are a little bit overtreated. But we do see evidence in the literature that if somebody is altered or has cognitive impairment and happens to have bacteriuria, it's still probably better to assess other causes of why they may be altered, other causes of why they may be having falls, for example, rather than just jumping right onto, oh, this is a urinary tract infection.
Yeah, thanks for that observation. I think that that's definitely where, an uncomfort level and people who don't know, there's a piece of the unknown there, right? And the thing you can't control is, well, I can treat it, like that, and that may prevent a negative outcome. So I think that unknown is always going to cause concern in any provider that's reviewing a patient. I think this can be even more difficult in the ambulatory setting where they're going to then go home and there's no one like watching them. They're not inpatient. We can't, let's hold off on antibiotics for a day and see how they're doing the next day. I think that concern is definitely heightened in an ambulatory setting where we don't have that type of monitoring.
One other thought that I had, and this is something that comes up in our clinic not infrequently, for people that get recurrent urinary tract infections, that can cause a significant amount of stress in their lives and disrupt their lives and cause anxiety around, when is that next UTI going to happen? And so I think a lot of those patients tend to push for more frequent screening, and there may end up being overtreatment of what are truly asymptomatic bacteriuria episodes in that patient population, just because there is so much distress that happens around episodes. And so that can be another more difficult case to approach, because there are occasionally or intermittently true UTIs mixed in with episodes of asymptomatic bacteria, and it can be really hard to discern what's real or not real there.
That's fantastic. I have kind of a follow-up question on that. So let's say, you get quite a bit of recurrent UTIs. I know that the RID clinic in general sees a lot of recurrent UTIs. Thinking through some of the biggest interventions that maybe primary care can try to make before they come to the ID clinic. I know that evaluating like topical estrogen cream, particularly in postmenopausal women, can be potentially a really good intervention to help reduce UTIs. Is there anything else you'd like to kind of like recommend to other providers before they come to ID Clinic, of things to try before thinking through suppressive antibiotics or something like that?
That's a great question. There are a number of things that different people have tried that may work for the individual patient. I think some of the evidence base is lacking in terms of this being a fix all for every patient. But I think things to try include asking patients, especially if they're premenopausal, if their UTIs seem to be linked with sexual intercourse, having them void before and after sexual intercourse can help. Cranberry tablet supplements. D-mannose has some evidence behind it, especially for people with recurrent E. coli urinary tract infections.
I definitely think that that kind of like almost bundle approach of like, here's some things to kind of try. Um, there's lots of different cranberry products out there. There's some that are super hype, super concentrated and may have a little bit of clinical evidence with them that might work better than just like a typical like cranberry pill. So I think that at least in my experience in our clinic, it does seem that every patient has a little bit different answer. So there isn't a one size fits all type intervention for this. And usually a lot of the stuff has been tried by the time they come to us, and then we're kind of assessing whether suppressive antibiotics are going to be more in the risk benefit category. So I feel like the decision to start suppressive antibiotics is always difficult, because I think we're always wondering, are we going to do more harm than good in those situations?
As people age, things that increase the risk of even just asymptomatic bacteria are incomplete voiding. So looking at those urodynamic studies can be really important. And then glycemic control can also play a big role here. So getting some of those things addressed or under control. If people have pelvic organ prolapse, then that can contribute. So trying to look at some of these risk factors that maybe are setting people up and addressing those can be sometimes more helpful than just trying to throw an antibiotic on board.
So I think we're going to kind of slide into our next kind of question here, and I want to kind of turn this over to Dr. Stornelli. But so we know we have an issue, and we've kind of talked about some of the issues with overtreatment and some rationales. How do we fix overtreatment? Like, what are some ways that we can give providers or a little bit more assistance in kind of assessing these situations and helping them feel better about not treating?
Yeah, I think that's a really great question, particularly pertaining to our elderly patients presenting, to the ED with that altered mental status that is seemingly undifferentiated. We do have multiple clinical pathways that kind of help provide some substance to the necessary steps to take in that patient population that are not septic. And so if your patient's coming in with just mental status changes alone, it's really important to kind of understand what was recently happening if that may be contributing to that from non-infectious causes, medication changes, hydration status. Is this related to, related to a separate issue other than something of an infection characteristic? So patients that are, not displaying signs of hemodynamic instability, that are afebrile, that don't have, a peripheral leukocytosis or anything like that, it's probably best to offer them some gentle hydration and evaluate all of those medications and potential for interactions and adverse events related to those first, with some monitoring for the first 24 to 48 hours. If you're really kind of in a difficult situation where altered mental status changes haven't resolved after the first couple of days of monitoring, there's no signs or specific symptoms noted of urinary tract infection, then it might be more reasonable to go down that pathway, rather than kind of treating from the start. So I think it's a little bit difficult because it does put a little bit of onus to delay an antibiotic, and I think that kind of gives some providers some pause reasonably. But as we kind of mentioned, there's some harm with upfront treatment of something this ASB in this population, and that you may cause down the road risks of actual infection or potential rehospitalization or ED admission. And so, one of the things that I think I try to talk with providers a little bit about is that, it is an active intervention, is sometimes withholding and just being supportive in the first 24 hours. And then maybe is the right time to potentially get that UA with reflex culture. I think, part of the questions that are often asked about therapy selection when you get an organism back is why was the UA, what was the intent of the UA with reflex culture to begin with? Was there a documented symptom? Was it just lethargy, altered perception, and deviation from the norm from an altered mental status perspective? And if really only the reason and rationale was that minor change in altered mental status, like there is a solid reason to kind of withhold antibiotics for a monitor or trial period if the patient just needs some hydration, or if there's new, medications, either anticholinergic medications that were just started, that could be a potential cause for that. That may need adjustment. It may need some internal medicine, or a medicine specialist to be able to evaluate that to make sure we're not perseverating a altered mental status there.
Yeah, thanks, Nick. That was an excellent kind of review of some of the concerns with overtreatment. I feel like the paradigm is almost like get a UA and then look for symptoms. It tends to be kind of the approach, and I think that we really need to kind of like flip that, right? Is like you start with a symptom, you have a symptom that makes you think UTI, and then getting the UA. I believe we have a new like alert that's going live at least Roanoke Memorial, that's kind of looking at being able to prompt folks for evaluating a UTI after 48 hours of admission, or if they're thinking about ordering a urine culture, there's a pathway that pops up and has them choose kind of what pathway they're thinking in terms of why they're getting a UA, to kind of help walk through that process and make providers feel a little bit more comfortable with, no, like waiting 24, 40 hours is totally cool. And I think that we all want to do the best thing for the patient as soon as possible. And sometimes that's waiting and watching, which doesn't make us feel very effective as healthcare professionals. It makes us feel like we're not doing anything. And that's definitely a difficult thing to overcome and justify to other folks, particularly when we're always doing throughput and trying to get people out of the hospital as soon as, if we're not doing intervention, why are they here? There's a lot of pressure on providers to make decisions quickly and from getting beds open and that sort of thing. So anything we can do to support providers to say like, no, it's okay, we might need to just watch them for a little bit to see how they improve. I really appreciate the two of you joining me today for our very first podcast episode. For listeners who might be listening, we are working through sound issues and seeing kind of improving our sound quality. This is our first attempt, but I really appreciate you listening along with us. I hope your thoughts today resonate with anyone else who might be listening. Please continue to follow our series as we're moving along. We have a new ambulatory stewardship website through CarilionClinic.org. So it's CarilionClinic.org /antimicrobial-stewardship. And then you can find there are ambulatory treatment guidelines for both adults and peds, as well as clinical tools for providers when it comes to microbiology and managing patient expectations. And also has information for Carilion providers on how to access our stewardship team and to use us for clinical questions. We're available both inpatient and outpatient to answer provider questions 7 days a week, and can also facilitate infectious disease consultation if that's the next step for patients. So appreciate the two of you joining us, and thank you so much for your expert. You guys have a wonderful day.
Thanks, Nathan. It's been a pleasure talking about urine with you.